Welcome to Grand Rounds today. We are thrilled to have all of you and delighted to welcome from Uptown, Dr. Cardi Smith, who, as you may know, is an associate professor of medicine in the Division of Hematology and Medical Oncology, and at the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine, where she also serves as the Chief Quality Officer for Cancer Services, and has been focused on lung cancer and palliative care in a lot of different ways, has received grants, including a fascinating recent grant I'm sure you'll hear about, and was named one of the 40 inspirational leaders under 40 back in 2015 by the American Academy of Hospice and Palliative Medicine. And she is here today to talk about achieving health equity in palliative care. Please join me in welcoming Dr. Smith.
Hi, everyone. Thank you. The most depressing part about that introduction is that I am no longer under 40, but that's okay. It happens, right? Right. Oh, I think you have to let me share my screen, whoever the host is.
Just made you a co-host, Dr. Smith. You should be able to now.
Oh, thank you, Ryan. Okay. All right, so you should be able to see my slides. Yep, okay. I will try to make this interactive. I'm learning as we go through Zoom ways in which to engage with this new platform. So if you have the ability to write in chat, please do so. I'll be asking you some questions as we go along. And so really my objectives today are to describe the current racial and ethnic disparities that exist in Pal care, and we'll talk about cancer a bit as well since my work intersects at the two areas, and to discuss strategies to improve disparities in palliative care for patients with serious illness. So I start with this MLK quote: "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And I would say that I agree. So we're going to do a little exercise, and when we're in person, we do this a little bit differently, but as with everything else, we are adapting for Zoom. So I'm going to ask you a series of questions, and for everyone that you respond with a yes to, I want you to give yourself a point. So a point for each yes. Just keep track of how many you have. I'll be asking about 12 questions. And at the end, I'll ask you to share in the chat box when you're done what your number is, if you feel comfortable doing so. So remember, a point for each yes. If you are considered a person, are you considered a person of color? Do you have a visible or hidden physical disability or impairment? Are you an immigrant to this country? Is your native language something other than English? Do you feel that you cannot show affection for your romantic partner in public without fear of ridicule or violence? Are you or a member of your family ever been incarcerated or have been in the juvenile justice system? Did your parents attend college? Or I should say, did your parents not attend college? Give yourself a yes if your family did not automatically expect you to attend college. A yes if your parents work nights and weekends to support your family. A yes if you never attended private school or summer camp. A yes if you were raised in a single parent household. A yes if you have never had a maid, gardener, or cleaning service. Now, once you have tallied up your numbers, if you feel comfortable putting in the chat, you can put it. I put mine there. I'm a 5. And as you are putting in your number, thinking about your number, seeing the numbers from other people here, you know, I think it is a reminder that we're all here, right? We all got to the same place, but the road traveled for some of us was very different. And it's not to say that if you were a 0, that life was super easy for you. It just means that your ability to get here was a little bit easier than those who may have had higher numbers. So thank you all for sharing that. And so I'll share with you my story, my road traveled, how I got to where I am. This is me on my wedding day, 15 years ago, September 2nd, 2005. So definitely was under 40 then. And the person in this picture with me is my father, and people say we look a lot alike. In fact, I'm actually named after him. His first name is Cardinale. My mom added the E, so I became Cardinale. And here, this was September 2005. He looked pretty good. He was robust. He had a nice belly. But what he didn't share with me on that day was that he had started having rectal bleeding about a month or 2 months prior to my wedding. And here he is a year later, September 10th, 2006, the day after the birth of my first and only niece, his first grandchild. And although, you know, digital pictures weren't really a thing back then, you can see that he's lost some hair underneath this hat. He looks a little bit older. He's not as robust. And this is because in April of that year, he had been diagnosed with stage 4 rectal cancer. He had mets to the liver and the lungs at the time that he was diagnosed. And he definitely fell into that category. My family's from Belize originally. In fact, I'm the first one in my family to be born in the US. And he fell into that, you know, male bravado, you know, we don't get colonoscopies, that's not what we do. He was 52 at the time that he was diagnosed and 54 when he died. So here is a picture. My niece in this picture is 10 months old, and he died a week after this picture was taken in August of 2007. And he was enrolled in home hospice for those last couple of months. And you know, this little cup you can see on this wooden table stand is actually liquid Colace, which I still find funny every time I look at this picture. But you know, our road to getting him here to hospice wasn't easy. I had started my Hemonc Pall Care Fellowship in 2006. And so right when he was transitioning to hospice, I had started my year of palliative care. And he lived in Brooklyn, and he would go to the pharmacies in Brooklyn to get fentanyl patches and oxycodone, which was what was given to him. And he was labeled as a drug seeker if he came in 2 days earlier to pick up a prescription, just because he had energy that day and didn't know if he would have energy the next day to get it. And often the pharmacies in Brooklyn didn't actually have those medications in stock. And he went into a pain crisis because he was then trying to wait for the pharmacy to get it in stock instead of just calling me for help. Often I just filled his scripts up here at Madison Avenue Pharmacy, which is now closed. And this was, you know, I was in the healthcare system as a physician and feel like, you know, I had an ability to better get him to care that he needed, and it was still really challenging for us. And so I think that, well, I know that this is really what put me on the path of health disparities research. And so when we think about palliative care, you know, I know I'm speaking to the choir here, but palliative care is really a medical specialty, medical care that's given to patients with serious illness at any stage of a trajectory of illness. It's given by an interdisciplinary team of physicians, nurses, social workers, chaplains, pharmacies, social workers, and others, and is really aimed at improving symptoms like pain and others, as well as helping with communication and transitions of care. And when we look at the definition of the healthcare disparities, the healthcare disparities is really defined by the Minority Health and Health Disparities Research and Education Act, which authorized the National Center for Minority Health and Health Disparities, or NIMHD, and it provided a legal definition of health disparities, and so that's there highlighted, which is a health disparity population exists if there's a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival. And so what is health equity? We talk about this a lot. health equity is really achieving the highest level of health for all people that addresses avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. And so we'll go through some of that in this talk. When we talk about equity, I really liked this example, this picture here. And it has since been updated. I used to show this picture a lot in my talks. And what it's really saying is that over here on the left, you see these three people, they're watching this baseball game. And equality is when I give everybody the same thing, right? So this really, the shorter person here, I'm giving him the same size box as I'm giving this taller person. But that's, just as we did with that exercise of giving ourselves the numbers, that's not necessarily enough. Equity is really giving those people who need more, and those who don't. You don't give them more. And that's where we get to equity. Where I think most of us would agree where we are, our current reality is over here on the left, which is that we're giving people who have more and more and more and more, or they're able to attain more and more for themselves. But what COVID has highlighted to us pretty significantly is that those people who don't have continue to sort of get dug down into a deeper hole. And where I think we really should be moving towards is this. This is really the social justice, right? So this is taking the fence away completely, so it doesn't matter how many boxes you have to stand on, you still are able to see the game. And when we think about New York City and we think about race, when we look at the 2010 census, here, this shows, so here's Central Park, right? Here's the east side, the west side, and then here's downtown. And the white color is represented by blue. White people are represented by blue in terms of where they live, Black and green, Asian in red, Hispanic in orange, and then others in brown. And the thing that's pretty striking here is that certainly there are neighborhoods that have peppering of other colors, but for the most part, New York City is pretty fairly segregated. And I think this really impacts outcomes that we see, across our health system and our institutions at Sinai. So that if you look at the average life expectancy from birth, it's very different depending on where you were born and live in New York City. So that if you were born here in Murray Hill or the Upper West Side, your life expectancy is much higher than someone who was born in East Harlem or in the Bronx. And, I'm a big Titanic fan. So here's, my Leo and Rose. And even in the Titanic, there was a difference between survival, right? So that first class lived more than those in the third class because they didn't have enough lifeboats for them. And it's interesting because I think that translates into every day. So I'm sure all of you remember when the US airplane went down with Captain Sully in the Hudson River in 2009. It's an iconic picture. It was a big deal how no lives were lost. And I looked at this picture so many times, and it didn't even dawn on me that we here too were witnessing an inequity. So that if you look here, the people in coach class, right, they're all standing on the wing in the water, cold because it was cold. But here in first class, they're all, they've got this nice life raft. They're not in the cold water. And, I think that, this is just a symbolism of how inequities touch our everyday life, and we tend to not even see it often. Often we talk about, isn't race and ethnicity really just a surrogate for socioeconomic status? And I think that's a bigger, deeper discussion because, race essentially, it's a social construct, right? We define, it's not based on any biology, we define it based on what we see with our eyes. And while often the two go hand in hand, the race, the color of someone's skin, the race itself is still a significant driver of many of the poor health outcomes that we see among minorities. And so this is showing you here in the pink and the purple that, really, almost 69% of people, of Blacks and Hispanics are living underneath the poverty line. So I'm going to take you a little bit through some of the historical context that leads us to where we are today. Very briefly, of course, you could talk about these things for hours, but some of them you may have heard of and others you may have not. So the first is Dr. Marion Sims, who is still referred to in some textbooks as the father of modern day gynecology surgery. And the way he did that is that he experimented on his procedures with Black slaves in the South, and he often performed these gynecologic procedures on these women, on these slaves, without using anesthesia. And the rationale behind that is that Blacks don't feel pain the same way that whites do. Blacks have a higher threshold for pain. Pain receptors are different. And so he performed these sometimes mutilating surgeries on these women with no anesthesia, and was able to really perfect techniques that are used in modern day surgery, gynecologic surgery. Next, we have Henrietta Lacks, and if you've not read this book yet, I highly recommend it. It's really good. This is Henrietta here in, a picture here, and then a drawing there in the middle. And so Henrietta Lacks, she died of cervical cancer. She was treated at Johns Hopkins, back when there was a separate area for Blacks and a separate area for whites. And she had pretty advanced cervical cancer already at the time of diagnosis. And when they did a biopsy, they collected her cells. And what they realized is that her cells are what they call immortal. It happens very infrequently where you have these cell lines that just continue to grow and don't die off. And her cell lines were able to be used for super important inventions like the polio vaccine, and among others. And yet, her family, even to this day, this modern day generation, still suffers from the same health inequities that Black people in the South tend to suffer from, and have had a lower educational attainment, and recognition of what these cells have been able to do and accomplish for them really wasn't recognized to them until just the 2000s, when Rebecca Skloot went to go write this book and to interview the family for it. And then finally, all of you, I'm sure, have heard about the Tuskegee experiment. Here is a picture where they actually advertised free blood tests, free treatment, bring in your family. And this was started in 1932. Researchers told the men that they were being treated for quote unquote bad blood, which at that time was a term that was used to describe several things, including syphilis. And here is a case study published at the annual meeting of the American Medical Association in 1936, untreated syphilis in the male Negro, where they started to talk about how they infected people with syphilis and then monitored them and did not treat them. And even though penicillin was accepted as treatment for syphilis in 1945, it wasn't given to these men. And then when ethics concerns were raised in 1969, the CDC reaffirmed the need for the study to continue, and the AMA supported this. The study ultimately ended in 1972, 40 years after the first person went with the disease. And ultimately, there was an out-of-court settlement that continues to support the 11 offspring that are currently receiving medical and health benefits as a result of this. But this sort of brief walk down history shows you that there, is a deep misrooted trust in Black communities in particular that's based off of real life things that have occurred, and isn't something that's going to be easily overcome. And so I'll walk you through the minority health and Pall care timeline as it pertains to when the federal government actually started getting involved in recognizing these inequities in care. And so we talked about the Tuskegee syphilis study becoming public in 1972. And I just think about that. I think about this all the time. I was born in 1978. And so although I feel that the world is a much better place than it was for my parents, it still is not that far off from my timeline. In 1985, the Heckler Report, which was the first report on Black minority health, was the federal government's first recognition that due to inequities in healthcare, Blacks and other minorities disproportionately experience more deaths from certain diseases than whites. And then in 1993, there was the establishment of the Office of Research of Minority Health. In 2000, we got the Research and Education Act, which really then spurred on the money for NIH to be able to conduct more research in health disparities. And then the Institute of Medicine, now the National Academies of Science, Engineering, and Medicine, came out with unequal treatment, and the first healthcare disparities report was published, recognizing all of the inequities that exist. And if we look at that in the context of palliative care, seeing how really just within the last several decades, minority health has been something that has come to the forefront of the federal government. You know, palliative care lags behind that even a little bit more. And then at Sinai in 1995 is when palliative care began. The American Board of Medical Specialties approved hospice and palliative medicine as a subspecialty of 10 boards in 2006. And then the first certification exam, which I was able to take, happened in 2008. And then the seminal Temel article, which showed an improvement in quality of life and also potential survival among metastatic lung cancer patients who had concurrent palliative care, was reported. And here are the publications from the IOM that have recognized that these disparities exist. And, you know, it's complicated, right? If this was easy to fix, hopefully we would have made much more improvement than we have already. But when you think about this from a research framework perspective, there are all of these levels of influence that impacts not just how a patient accesses care, but also how they're able to receive it. And there are all these domains of influence, some of which as a healthcare system we are set up to help with, many others we aren't, but are sort of forced to try and help with to the best of our ability. And this is really where that concept of social determinants of health comes up, right? Recognizing that when a person comes in to see me, that it's much more than just their blood pressure and the pill that I'm prescribing for them that impacts the way in which, one, they believe they should take that pill, two, they're able to go to the pharmacy and fill that pill, three, the ability for them to buy it, you know, and then so on and so on and so forth. And yet, these are the other levers outside of the healthcare system that we in healthcare often aren't really charged or leveraged to be able to impact as significantly. And so if you will give me a couple of minutes, I'm going to frame what Dr. Kamara Jones, who is a healthcare disparities researcher, calls as the cliff analogy. I really like it, and I think it's a really nice way that I contextualize sort of the healthcare disparities framework. So if you think, here's this cliff, this line is the cliff, and you have all of these levels of health intervention. So in B, you have a bunch of people who are standing really close to the cliff. And if something happens to them, they get sick, they fall down off the cliff, well, they're just really falling down into a flat valley, they go splat, badness happens. Then we get to F. Well, all right, well, we don't want that to happen again. We want to be able to catch people somehow to be able to help them. So we put an ambulance down here in the valley. And if someone now falls, there would be an ambulance there. But if they fell, they sort of fall on the ambulance. So we need to help them a little bit. And then G, we give them this net, right? This net, they can bounce on top of it so that hopefully they don't fall through the cracks. But because there are holes, there are cracks, people can sort of slide through. Well, instead of making them fall, how about we put up a fence, which is what you see in H, to prevent them from falling, right? So here's like your primary care, your fence. Or even better in I, take them away from the fence and just scoot them back so that they're not even at risk. And this would be access to, good care from the beginning. But because we live in the three-dimensional world, we are not only just one community, we are made up of several communities. And so here in B, you see we have our two communities. They're both back from the fence. There's a fence, there's a net, and there are ambulances. But in C, this ambulance here closer to the screen has a flat tire. So if somebody were to fall, then that ambulance wouldn't be able to take them to urgent care like they would need to get. the care they need. Or in D, if somebody took that ambulance to get urgent care, now there's no ambulance there waiting for them to help them. Or in E, they could not have an ambulance and not have a safety net to catch them. Or in F, not have a fence, a net, or have the ambulance. Or in G, they could actually still be very closer to the cliff. Meanwhile, the other community here is still doing pretty well because they have all of the preventative measures and the measures in place to help catch them should they fall, and they are far behind the cliff. And so when you think about these different scenarios, differences in quality of care is really what are these services that someone has, these ambulances that exist or not. Then there's the differences in the access to care. So whether or not you have this fence or this net to help support you. And then there are differences in exposures and opportunities. So how close you are to the fence or away from the fence. Sorry, I went the wrong way. So that when we think about this, this is really health services are all of those, all the fence, the net, and the ambulance, but the social determinants of health is really how far someone is to that fence. And then the social determinants of equity is not just how close or far away they are from the cliff, but also the services that they have to give to help them. So hopefully that was a little illustrative of what we're dealing with and why this is really so challenging. So when you think about, well, what factors contribute, right? What are some of the other things on the clinician standpoint that may be contributing to what we see in terms of these inequities? And so this study was published not that long ago in 2016, and study 1 consisted of sending a survey out to lay people, and study 2 was giving a survey to first, second, third year medical students, and then residents. And they asked questions about biological differences between Blacks and whites and what their beliefs were around those differences. So Black skin is thicker than whites. Well, unfortunately, the vast majority of the non-medical community, 58% of people believe that. But when you look here at those in medicine, I mean, it wasn't 0. I mean, the best it got was 22% in those third-year medical students. Blacks age more slowly than whites. Again, there was this misperception that, in fact, while I personally selfishly wish that were true, it is not. And then lastly, when you look at all of the composite of the false beliefs, that, you know, still those folks out in residence, there are about, 15% of them that had some false belief. And so if at baseline, we as clinicians believe that in fact there are differences, then the way in which we would move to approach that care will be different. And so here you have this cartoon with this gentleman reading a paper that says, reports whites get better health care, telling his wife, I finally understand why Michael Jackson bleached himself. And that's harder when, like, I can't hear you chuckle, so I'm just going to assume my joke is funny. And the Disparities conceptual framework really consists of access to care, thank you, Matt, receipt or quality, and we'll focus first on the access piece. So when we think about palliative care we know is available in 72% of all large hospitals defined as medium to large hospitals defined as greater than or equal to 50 beds, 94% of mid to large size hospitals, and yet only exists in 60% of public safety net hospitals. And particularly there is poor availability in South Central of the United States, and less than a third of the hospitals in Arkansas, Mississippi, and Alabama report having a palliative care team. And so these are areas where we know we have higher rates of racial and ethnic minorities who, would benefit from these services, but they don't really exist. And when we look at clinical trials specifically in palliative care, these are race and ethnicity characteristics from the trials that were included in the 2012 and 2017 American Society of Clinical Oncology recommendations for who should get palliative care. And those recommendations say that anyone with an advanced stage cancer should receive palliative care, but yet that's based off of all of these studies here, which really had a very low If you look here at the top, white, Black, Asian, Native American, American Indian, other, and then Hispanic, they had a really low rate of racial and ethnic minorities included in these studies. And I'm not saying that racial and ethnic minorities don't benefit from palliative care services. What I'm saying is that they're not integrated into these studies as much. And so the magnitude of benefit, or how we provide those services to them, or the ways in which we give care delivery, isn't being measured and is important. And so, you know, among the patient trials with race and ethnicity data, 10% of participants were Asian, 9% Hispanic Latino, and 6% African American. Work that I did here actually when I was a fellow, looking at differences and disparities in lung cancer treatment throughout the trajectory of care, asked both patients and clinicians, and in this case, clinicians were any lung cancer provider, medical oncology, radiation oncology, pulmonary, or surgery, their beliefs about fatalism and preferences for a DNR order. And so while that seemed to be congruent with patients' beliefs, when we asked about hospice and palliative care, you know, providers' beliefs about prognosis, discussion preferences, willingness to accept hospice and palliative care referral are not consistent with their minority patients' beliefs, and that more clinicians believe that patients would not want to have a palliative care consult, where in fact a fair amount of patients said that they might actually be willing to accept it. And if the clinician is the mode of access, right, it's referral based only primarily, then they're not going to be able to receive that. And so here's an article from the New York Times in 2016, finding good pain treatment is hard. If you're not white, it's even harder. And so I think pain is probably, you know, one of those palliative care symptoms that we know the most about as it pertains to disparities. And so we know from the physician standpoint that physicians tend to underestimate pain. In this study, patients and physician perceptions of pain in 12 academic medical centers were captured, and physicians underestimated pain in 33% of non-Blacks as compared to 47% of Blacks. And that was significant, meaning that we're not even assessing their pain completely. And work that Sean Morrison did, he's the chair of Geriatrics and Palliative Medicine from Mount Sinai now 20 years ago, if you can imagine. And I keep saying I want someone to help me do this study again. So if any of you are interested, you can email me, because given where we are with the opioid crisis, I'm very curious as to whether this still stands. But he surveyed the adequacy of opioid supplies at 347 pharmacies, according to racial and ethnic composition of neighborhoods, primarily in the Upper East Side and Harlem. And what they found are that those pharmacies who had primarily communities of color were much less likely to stock adequate opioids in their pharmacy. And when asked why, the barriers that they identified, you know, included more than half saying that there was a little demand for these medications, therefore they didn't keep them in stock. Almost half were concerned about how to dispose of them. There was fear of DEA investigations or robbery, and then some cited problems with reimbursement. I mean, as I shared with you and my own father, we had this issue, and certainly as a physician, I have this issue when I am prescribing opioids for my patients, such that when patients are not getting their opioids from our immediate pharmacy area to the hospital, my team will call their pharmacy to ensure that they have these meds in stock, because it is a big issue. And I would say that that same study has been replicated in other urban environments, particularly in Detroit, to show that it's the same. So this sign says, the system isn't broken, it was built this way. And now we'll talk about receipt. So this is a pretty famous, at least in my world, meta-analysis of the receipt of care for pain among whites, Hispanics, Blacks, Asians, and Native Americans. And this meta-analysis looked at pain studies throughout 1989 to 2011, and it was both patients who were receiving pain meds for traumatic pain, meaning presenting to an acute care setting for management of trauma or surgery, and then non-traumatic related pain. And what it showed is that for Hispanics, particularly, they were less likely to get opioids. And for Blacks, they were less likely to get any analgesia, whether it was opioids or COX-2 inhibitors. And sadly, this also is pervasive in pediatric literature, and that in the pediatric literature for kids presenting with acute appendicitis, for example, there's data that demonstrates that, you know, Blacks and Hispanics children are less likely to receive the same, are less likely to receive analgesia opioids than their white counterparts, and are much more likely to get treated with things like NSAIDs. And so I'll present to you a study that we did here, looking at improving goals of care conversations among oncologists. So we randomized oncologists at 4 sites. It was Chelsea, Mount Sinai Hospital, ambulatory practices, a rural practice based in Yale, and then Kings County in Brooklyn. And we randomized oncologists in practice to receive an intervention which consisted of an hour grand rounds, where we talked about the importance of communication and laid out some basic communication skills. And then there was a 2-hour simulated role play workshop where we taught those communication skills. And then we had 4 joint coaching visits. So we had communication coaches or facilitators of these communication training programs work in real time with the oncologist and watch their actual real-time patient encounters to coach them in communicating. And then the usual care arm participated in grand rounds only. And then we watched and followed patient outcomes. And so patients were included in this study if they had an advanced solid cancer with a prognosis of 2 years or less, if they were able to speak English. And we set these visits up so that this was their scan post-initiation of first-line systemic chemotherapy. So I have a new diagnosis of a stage 4 cancer. I started treatment and I'm coming in for the results of my first scan. So at the time, the discussion is either, you know, unfortunately there is progression, or things are looking well. But in any event, there's always an opportunity to talk about values. And so here are the baseline characteristics. We enrolled a total of 22 physicians and 142 patients. And you can see that the demographic, the racial and ethnic demographic breakdown was pretty good, with about 1/3 being Black and Hispanic. And then when we looked at encounter times and quality, we identified that oncologists spent less time in these sort of goals of care conversations with their Black and Hispanic patients than they did with their white patients. And so overall, in the unadjusted analysis, it was a 5-minute difference, so 17 minutes versus 12. If there was progression of disease, there was no statistical significant difference in the time the oncologist spent. But if there was no progression, there was a 5-minute difference. We also asked patients about the quality of those goals of care conversations. So on the scale of 0 to 10, how would you rate the quality, with 10 being the best? Sorry, with greater than or equal to 9 being described as high quality. And you can see that there was a difference in both those who described the quality of the conversation as high or low, and yet overall about 70% of both groups reported having high quality conversations. In the adjusted analysis, after adjusting for insurance, education, income, progression, and clustering within hospitals, we found that oncologists spent 3 minutes less with their minority patients than their non-minority patients. And so that was 17 minutes with whites and 14 minutes with Blacks and Hispanics. Now we're doing a deeper dive into that data to try and get a sense of what's actually happening in those conversations that's contributing to these differences. And thus far, you know, we can see that the minority patients are talking much less. The number of questions asked by the oncologist is less, and the number of questions asked by the patients are less. But, you know, it's 142 audio recordings, and so we are hopeful that we will be able to get through it rather quickly, but it certainly is interesting. And so now if you will indulge me, I want to show you a brief video. And while you're watching the video, it's like 3 minutes. I want you to think about what you're seeing and tell me about.
Need some help here? 2 GSWs, hope you're in the mood.
What happened?
Drug deal went bad, guy opened fire on fly.
And I'm gonna pause for a second. Can you all hear that? Okay, thumbs up, great.
On 3rd.
Injuries?
Single GSW.
Mother hurts.
To the left flank, vital stable, good breath sounds. IV saline TKO.
Some guy shot me. Yeah, some guy.
It's always some guy.
Doyle, get him into trauma too. Malik,
17-year-old employee hit in the lower left chest.
check for weapons and needles.
Push him through and through to the right deltoid. BP's falling 90 or 55. Sinus peak at 120. 2 large bore IVs. A liter of saline in. O2 at 15 liters.
This one's more critical. Grab the portable from 2. Each and H, time across 4 units. Give you 2 units of O negative just in case, and a portable chest.
We give him something for pain.
Stand by with morphine. I guess you need to get hazard pay for slinging burgers these days.
Belly's tender. Set up a lavage.
Pulse ox is 92 on 15 liters. And up 1 gram.
You might have a peritoneal violation. Give him Suboxetine, same dose.
What do you got?
I got a cake for you to walk. Exam 2. I need a surgical consult on a lovely 50-inch crackhead sent over courtesy of the St. David's ER.
Oh, that sounds like a dump.
Yeah, well, you lost fair and square.
What about this guy?
But forget it, Carter. It's Gomer tag and you're it.
I can't believe he shot me.
Where's Malik?
Calling radiology.
I was just standing there, man.
Be quiet and hold still so I can...
You okay alone?
Yeah. Didn't have a gun or any needles.
Gun? I don't want no gun.
Call me if you need me.
Can I help you?
Yeah, I'm looking for my brother. He's been shot.
Visitors can't go in during a trauma. Go to the desk and tell them you're here. Someone will come talk to you.
Kenny! Kenny, all right? Chris, I got shot.
You have to wait outside.
It's my little brother.
Okay, but you still need to wait outside.
Look, the cops won't let me pass the tape, and the medics won't let me in the ambulance. I'm staying right here. Got you, Kenny. I don't know. Give him something. They think I'm a gangbang. Oh!
I haven't finished assessing him. Please, wait outside.
Positive.
Page Beth.
Why y'all swarming on this boy? Huh? My brother's in there dying.
Nobody is dying anywhere. Please, family members need to wait outside.
You in charge?
Malay, could you,
Send no sister over here to shoot me away. Get your ass in there. Fix him up now.
we treat the most critically injured patients first.
Kenny's been shot.
You are tying up the staff and delaying your brother's treatment. So why don't you wait outside?
We got work to do.
You think he's a gangster?
We treat everybody the same.
Same? Same for the white boy, one for the brother?
Dr. Green, an agent here.
Lydia, come with me.
You bring it down. His BP bottomed out.
Do you have anything?
No.
All right, give me a 14 gauge.
Pulse ox is only 85. Lungs sounded okay to me.
He's got tension pneumo.
Set up a fluoresceal. Sterile gloves.
Get that portable in here.
Neck veins are coming down.
What happened?
You've got to constantly reassess a penetrating trauma.
What's wrong with him?
BP's only 70 palp.
Doyle, I'm going to put in the chest tube, okay? You set me up with a 32 French.
But I told that doctor my brother needed help.
Yeah, your brother be fine. What's his name?
Kenny Law.
Southside basketball kid?
Yeah, man, you got to represent for him.
Yeah, he was all city point guard.
Yo, black man, you a doctor?
Yeah.
You need to get here and take care of Kenny.
Guy's table, go ahead. Sure. Yeah.
Hey, you, get off. Don't you touch him. Come on.
All right, I need a new tray. Someone call security.
All right, what's going on?
I got a tension pneumo trying to get chest tube in.
All right, look, just let us do our jobs, all right?
Make a fast repeat and hang a unit on Nick.
2 units breaths.
Hook up the thoraceal.
Okay. So I'd love for you to take a minute and throw some thoughts in the chat box about what you just witnessed. And for those of you, I hope you all know what that was, but that was ER, which was a really great medical drama series. Yeah, a powerful example, I agree. Powerful of, of what? Yeah. Oh, hey, Brittany. Yep, assumptions and stereotypes about the young Black man. That's right. Right, that they automatically assumed he was the drug dealer. That's right, Black equals drug dealer, while it was the white person from the suburbs who in fact was doing it. And, you know, dare to say that there was some, you know, that the care that was given was done in a way that preferentially favored the white equals good person, right? And not having the trainee alone in the room with the white person, but was there with the Black person. You know, you can feel free to go on and watch that. I'm happy to tell you which episode it was. Unfortunately, the black man died in that video. In that episode. So this gets us to the disparities in the clinical encounter, right? Which is that, you know, how can well-meaning, highly educated health professionals working in our usual circumstances create a pattern of care that appears to be discriminatory? And this is where implicit bias comes in, right? So implicit bias is really, you know, we all have our normal cognitive processes, and we've all been shaped to believe things in the way that we've grown up in our environment and seeing others and how we've been socialized. And it shapes our expectations, how we share information, how we act, and how we communicate both verbally and non-verbally, and ultimately what we recommend. And so this concept of this unconscious bias is essentially that so much of our social behavior is driven by learned stereotypes that we just operate automatically and therefore unconsciously when we interact with other people. So when I'm, you know, in my busy oncology office where I get my 20 minutes to see these patients, I make these snap minute decisions about what this person can or cannot do, or what's contributing to what I see in front of me. And that's just based off of my own stereotypes and how I've been trained. And we know that there are environments in which we sort of push implicit biases to happen more. And those tend to be high stress work environments. I'm not sure if that sounds familiar to any of you. So the gold standard way to test for implicit bias is with something called the implicit association test, and the website for it is there. I highly encourage you all to take it. And essentially what the implicit association test does is it's an indirect measure of an individual's implicit attitude, so that images appear on the screen and you respond by sorting pairs of images and attributes using right and left keys. So that the premise here is that you'll respond faster to concepts that are more strongly associated to those that have more weak associations. So if someone matches white plus good and black plus bad faster than black plus is good and white is bad, then the race IAT score differs from 0 and is positive and gets labeled towards having a white preference. And so here you see then whites with the unpleasant concepts and then blacks with the pleasant concepts. And when you look at the lay population, so this was them looking at the approximately 730,000 respondents on their website between July 2000 and May 2006. You know, 70% majority of those who took this test had a preference for whites, compared to only 12% having a preference for blacks. And when you look at the meta-analysis that was done looking specifically at clinicians, it mirrors almost the general population. And that here you have, that should be 24%, but here you have 66% with a preference towards whites and 24% with a preference towards blacks. And so here in this cartoon, this gentleman reading this article that says minorities receive inferior health care, the guy says, I'm worried about the quality of my health care. And his buddy says, relax, you're all white. All right, so how do we move towards health equity, right? I showed you all the reasons why it's happening, how it's happening, and what are some of the ways in which we can make it better. Well, Palcare, for example, is one thing that can help mitigate some of this difference. In this study that was a institution study before PalCare became sort of standard. They looked at patients who were admitted with an advanced cancer and evaluated those who received a PalCare consult and those who did not. And we pulled out those patients who received a PalCare consult and looked at differences among minorities and non-minorities. And so at baseline, you can see that there are some differences in marital status with minorities, and minorities here being Black and Hispanics, less likely to be married, having a lower educational attainment. There was some difference in cancer types and difference in religious preferences. And then before receiving the palliative care consult, there was a difference in the condensed memorial symptom assessment scale, basically saying that minorities had more symptoms. They reported taking pain medications less, having less relief from pain medications, less likely to have a healthcare proxy, living will, or to have talked about their wishes. And then after the palliative care consult, essentially all of that went away except for worry. They were actually less worried after the PalCare consult, suggesting that minority patients certainly benefit from the palliative care approach. And here you see the percentage of uninsured adults between 19 and 64 by race and ethnicity in the US between 2010 and 2018. And what's most stark is this big dip that happens in the number of uninsured, less people uninsured. What do you think contributed to this? Oops. Yeah, that's right, the ACA. So we can thank the Affordable Care Act, thank you, President Obama. And here this shows the changes in those rates among groups by Medicaid expansion status. So for those states that expanded Medicaid here in the middle versus those states that did not, and then looking at it by Blacks, Hispanics, whites, and then your percentage either under or over the federal poverty line. And this essentially shows us that those states that expanded Medicaid had more improvement in the rates of uninsured, showing us that we know how to make this better. We know how to get access to the care, access to people who need it. And you may probably remember this picture, and I won't get too political, but I will now say, now that we know there's a problem, right, what do we do about it? I can tell you that for us in cancer, we're really looking at disparities in all of the ways in which we impact our patients with cancer, so that we've created what we call a cancer disparities dashboard, looking primarily at these cancers listed here to start, but we'll be expanding out to other cancers. And we're looking at these particular outcomes that we measure and track, and the hospital measures and tracks because they deem it as important, focusing first specifically on in-hospital mortality and hospice discharge rate. So this is a super busy slide, but essentially shows you that we can look at the number of patients within each of these categories. And if we focus specifically on breast cancer, for example, for patients in our cancer registry between 2016 and 2018, we can start to look at what some of these differences are. So this is referral to hospice, where we see here white patients are at about 10% of these breast cancer cases, and Blacks are at about 3%. And so we can start to look at this and see signals for opportunities for improvement. And so your action items, of course, is to vote. I will say my birthday is November 6th, 3 days after the election. So please give me a really great birthday present, unlike 4 years ago. And then sign up others. My nephew just turned 19, and I made sure that, I don't care how they vote, but I made sure he signed up 5 of his friends to be able to vote in this election. The census is super important, right? The way in which we are provided with funds matters. The Institute and the Office for Diversity and Inclusion are offering lots of opportunities for implicit bias training and anti-racism training. I think particularly for us in cancer, I can't speak for many others. I know we don't do a great job of screening for social determinants of health, and that is a priority that we have set forth for ourselves for 2021. I really think trying to diversify the oncology workforce, which is something in the Pall care workforce, all workforce really, in oncology specifically, less than 5% of all physicians self-identify as Black or Hispanic. And so there's a lot of work to do. I think in your own patient encounters, being really intentional. So one of the things that I do with my clinical team is when I see a patient, primarily with lung cancer, which is what I treat, and I'm offering them a treatment that is not standard of care, in my team and we have come to this agreement that we have to push each other and say, why are we not offering them the standard of care treatment? Or why are we not following what we would normally follow for other people? Because, there may be bias inherently built into those decisions that we're making. And ultimately, commit to doing one thing and just start it, because that's really the way in which you will impact change. And so I have tons of people that I have to thank. I won't name them all throughout my journey here at Sinai and through the research that I do, both in terms of mentorship and collaboration. And of course, I'm going to leave you with a quote from Ruth Bader Ginsburg: "Real change, enduring change, happens one step at a time." And so with that, I am happy to take, I don't know if we do questions or how this works over Zoom anymore, but I thank you for your time.
So much for a fantastic lecture, Dr. Smith. That was an incredible grand rounds. We do have a few minutes for questions. We'll try not to keep people over the 1 hour time period, but if anyone has any questions, feel free to unmute yourselves or utilize the chat function, and we will look in both. We'll give everyone a minute or two in case they're typing. Looks like there's a question from Brittany in the chat that states, are there other legislative opportunities that you think can help reduce disparities for marginalized groups?
Yeah, I should ask you, Britt. I'm assuming this, yes, I see your picture, Brittany. I should ask you that because you probably know much more about what's happening in the legislative world than I do. But yes, I do. I think when I think specifically about healthcare, I think about the social determinants of health. And I think that from a legislative standpoint, we don't often focus on those things critically when we pass legislation, either around how they, like through the Affordable Care Act or others, whereby we mandate payers or healthcare systems to at least be able to track this, to be able to report out on it. I think until we start doing those things, we're never really going to be able to impact truly meaningful change.
Any other last minute questions before we close out grand rounds for the afternoon? Looks like Isabel asked, what unconscious bias workshops are being provided by Mount Sinai at this time to provide further insight on health inequality in medicine?
I don't have the dates off the top of my head, but the Office for Diversity and Inclusion has a website, and a lot of those dates and times for like anti-racism training and bias training are listed on there.
Perfect. And then Dr. Berger also asked, I think something that we're all thinking, right? What can we do each day to change the system?
Yeah, honestly, recognizing that a problem exists is number one. And then I think, each day in your own practices, as you approach patients, typically, I see this scenario a lot. We write in the chart, a patient is non-compliant, right? Or they're non-adherent. or, you know, there's concern about drug seeking. And then that just gets perpetuated in the chart, but no one actually takes the time to sit down, or I shouldn't say no one. Rarely does it happen that someone sits down and says to that patient, why aren't you taking this medicine? What are the barriers? What is challenging here for you? Because you know what you might find out is that they can't get it. They don't have enough money, or maybe they saw someone have an adverse reaction to that medication and they're unwilling to take it. I mean, I think it is taking away those stereotypes that we tend to perpetuate so much in medicine, and really just starting from scratch and sort of blank template, like you've never even heard it, and, you know, start again. That's a start.
Awesome. Unless anyone has any last minute questions, I think we will end it on that note. Thank you so much, Dr. Smith. We really appreciate you taking the time to give us a Grand Rounds lecture today. Really, really appreciate it. And otherwise, I hope everyone has a great afternoon. All right, we'll end Grand Rounds for the day.
Bye, thank you.